So I apologize for the inconvenience. Uh, Hope you all felt the last two or three classes on respiratory physiology were useful to you. On similar lines, we are going to see some of PR segment, and this PR segment, if it gets prolonged, that means there is a further delay. So you will identify the degree of block. We talk about first degree block, second degree block. So even though we say PR segment, PR interval gets prolonged, it is the segment which will get prolonged more and more. Okay, and that will be prolonging the PR interval. Okay, so that is how the block or conduction defect also happens. So we have two segments. One is ST segment, another is PR segment. And we have one PR interval, there is a QT interval, ST interval. So there are three intervals in the ECG. PR interval, ST interval, that is in time interval between the S wave and the T wave, and QT interval, starting of the Q wave to the T wave. So the three intervals and RR interval to calculate the rate. So four intervals actually. So PR interval, ST interval, QT interval, RR interval, and two segments. One is PR segment, another ST segment. We commonly talk about ST segment, elevation, depression, all these things, whereas PR segment is not very frequently talked about, but it has a lot of importance. So I thought I will include this in the discussion. Now, what is the significance of RBB and left BB? That is right bundle branch block and left bundle branch block. Most of the times we find that a healthy patient coming, ECG shows there is a evidence of right bundle branch block. Do we have to worry about that?
Usually the RBB pattern is physiological.
Maybe physiological or congenital also. So RBB we normally don't worry much about. It may be a congenital change, but does not cause any threat to the life. Whereas left bundle branch block, is it very common?
Always
Left bundle
pathological.
branch block means block in the these fibers supplying the left ventricle. So these are all the fibers which supply the left ventricle. So left bundle branch block means left ventricular function will be affected. So normally we don't come across LBB, but a freshly occurring LBB indicates that there is a occlusion in the left coronary artery. So the left bundles are not supplied properly. So RBB can be either physiological or a result of damage to the right bundle branch, which may be especially when the right bundle can be injured hydrogenically. Which particular surgery, congenital surgery in the heart, when you do, you can cause damage to the right bundle.
Tetralogy of Fallot.
Tetralogy of Fallot or any hole, high VSD, which is high VSD means the origin is here. High VSD encroaches upon the atrioventricular groove, almost close to the atrium. So when you try to close that by pulling the septum and try to close that, you may injure that. Okay, or a high VSD, separate the high VSD, you can block, or as you said, Fallot's tetralogy also, you can damage this and produce a block. So causes damage even in lung conditions, you may get an RBB because of the delayed conduction of impulses, and pulmonary emboli, carpulmonale, congenital heart diseases like ASD, ischemic heart disease, and primary degeneration of right bundle. All these things can produce, but it is most of the time it is quite innocuous. On the contrary, left bundle branch block is always pathological. As we said here, RBB can be physiological. So if it is happening in a young healthy person who has no cardiac complaints and you find the evidence of RBB in the ECG, you can ignore that unless he has had other problems which can produce a pathological right bundle branch also. Whereas if you find the evidence of LBB, it is always pathological. Left bundle branch block may be due to conduction system degeneration or myocardial pathologies like ischemic heart disease, cardiomyopathy, or valvular heart disease. And especially if earlier ECG of the patient is normal and you find a new onset left bundle branch block, you must think of a silent myocardial ischemia in that patient. Okay, so you should not ignore that. You must investigate thoroughly before giving fitness to such patients. Now, what is the innervation of the heart? How is it innervated? We saw about the coronary supply, we saw about the venous drainage, we have seen the conduction system. Now we have to know about the innervation which controls the heart activity. What are the main supplies which control the heart function? Which one causes tachycardia? Which one causes bradycardia? As simple as that.
Sympathetic chain causes
Sympathetic
tachycardia.
stimulation causes both chronotropy and inotropy, whereas parasympathetic causes conduction delay and bradycardia, isn't it? So branches from both parasympathetic and sympathetic system contribute to formation of cardiac plexus. This plexus consists of superficial part inferior to the aortic arch, and between the pulmonary trunk there is a deeper part. So this cardiac plexus, which has both sympathetic and parasympathetic supply to the heart, has got two parts. One is the superficial part, which is inferior to the aortic arch. Then there is a deep part which is between the pulmonary trunk and the aortic arch and the tracheal bifurcation. Okay, so this becomes important, especially when the surgeons are doing the cardiac surgeries. You have to be careful with the without damaging this, especially when you do aortic arch surgeries. You have to be very watchful and make sure that you don't damage them. Now, what is the blood supply to the conducting system of the heart? Which are all the blood vessels which supply? So, as we said, majority of the patients will receive SA node receives blood supply from 85% from coronary, right coronary, 15% from left coronary. Okay, so the whole conducting system of the heart is mainly provided by right coronary artery, with the exception of part of the left branch of the atrioventricular bundle. That is, the bundle of His may be supplied by left coronary artery. So if you find any bradycardia and hypotension in a myocardial infarction patient, invariably it is a right coronary artery disease. On the contrary, if you find the tachycardia and hypertension, it may be mainly left coronary artery disease. Okay, so describe the features of Purkinje fibers. This is a physiological thing. So Purkinje fibers are subendocardial plexus of conduction cells, and which are networks of again specialized cells. They are abundant with glycogen and have extensive gap junctions. They are located in the subendocardial surface of ventricular walls also, and are able to rapidly transmit cardiac action potentials from the AV bundle to the myocardium of the ventricles. So individually all the myocytes have to be stimulated. So for that only these Purkinje fibers are very helpful, and they are very high energy utilizing fibers. That is why they have a lot of glycogen to maintain their continuous activity without getting exhausted. Now, what is the need of for artificial pacemaker? When will you require a pacemaker? What are all the indications? This is another practical application we should know about the conduction system. When will you have to put in a pacemaker to a patient?
When
nowadays we get a lot of elderly patients, pacemaker coming to surgery. Huh?
When we suspect a third degree AV block.
So clinical relevance of artificial pacemaker is a small electrical device commonly fitted to monitor and correct heart rate and rhythm. It is inserted into the chest under the left clavicle with wires connected to the heart via the venous system. So we push the electrodes into to touch the heart through the subclavian vein, and push it into the right atrium and right ventricle where we want that to be tolerated. The most common indication is sinus bradycardia. Okay, patients who develop bradycardia mainly because of the sinus disease, sick sinus syndrome, or other reasons producing bradycardia, or total conduction defect between the atrium and the ventricle, which is called the complete heart block, which independently makes the atria and ventricle contract without synchronization. So these are the two most important indications for an artificial pacemaker. So once inserted, the pacemaker monitors the heart rate and only fires if the rate becomes too slow. Pacemakers can also be used to treat some tachycardias and certain types of heart block and other rhythm abnormalities. So it is mainly these are the indications. Now, what are the properties of cardiac muscle? How cardiac muscles are separate or specialized compared to our other muscles in the body, voluntary muscles in the body, or involuntary muscles which are there in the intestines and other areas. So the properties of cardiac muscles are they have rhythmicity, automaticity, and chronotropism. Okay, and they also have excitability, which is called bathmotropism, and there is a property of contractility, so inotropism, and there is a property of conductivity, which is called dromotropism. So these are all the terminologies which are commonly used to indicate the properties or characteristics of the cardiac muscle. Chronotropism means rate. So they are able to alter their rate depending upon the need. They are able to get excited by stimulation. That is called bathmotropism. And if they are able to improve their contractility to augment the cardiac output, it's called inotropism. And if they are able to do a proper conductivity, it is called dromotropism. And what do you call their ability to relax? Lucid tropism. Very good. Lucid trophy or lucid trophy. So 5 tropisms you have to know. Chronotropism, bathmotropism, inotropism. Chrono and inotropism we commonly use. But the bathmotropism, dromotropism, and lucid tropism we don't commonly use. But the meaning of that is bathmotropism is excitability, dromotropism is conductivity, and lupitrocism is the relaxing ability. Unless they relax properly, they cannot hold more blood. So when the patient goes in for diastolic dysfunction, the relaxing ability of the myocardium decreases. So patient will not have a larger cavity to hold more blood. So that is what you call it as a diastolic dysfunction. So lucid tropism is very important. Now I am going to show you a picture which is showing something. A portion of the heart muscle has been put under microscope and you are seeing them in under microscopic vision. So what is the peculiarity of the myocytes? Like
multinucleated, continuous, multinucleated, multiple nucleus and continuous.
So one cell is getting connected to another cell, something like a bridge like that. What do you call that?
Syncytium.
Syncytium. Syncytial arrangement, very good. Syncytial arrangement of the cardiac myocytes. So unlike your individual myofibrils of your voluntary muscles, the cardiac myocytes have got a syncytial arrangement, which we have all studied in our basic physiology class. So if you stimulate one muscle here, it will pass on that to other portion. That is how the muscle is able to, you don't have to have too many muscle nerve fibers to stimulate. So even if you stimulate one portion of the muscle, the electrical impulse will pass on to all these muscles. So this inter-muscle connections, that is called the syncytial arrangement of cardiac myocytes. Okay. And describe the cardiac skeleton and its contraction. Of course, this is more similar to other things, but in the atrium, the musculature is situated like this. So you can see the contractility is right and left atrium contract towards each other, like they are able to push the blood downward. Whereas the ventricular muscle, it is like wringing a towel. You see the ventricular muscle contracting activity. When you want to dry a cloth, you twist it It's called wringing the towel. So similar, that kind of action only produces. Here, this type of contraction is mainly to push the blood from the atria into the ventricle, whereas here it is to push the blood with force out of the ventricle so that it can reach the entire circulation. Okay, so the contractility angles or axes are different between the area and the ventricle. So this is another picture to show how they are all cardiac skeleton is working, and even the muscle fiber arrangement, how they are in the atria and ventricle is shown here. Now, what is the contractile cell of the heart and how its contraction is caused? What is the name for the contractile cell? What we saw in the conduction system is the pacemaker cells or the stimulatory cells. They don't do the contraction. And once the electrical impulses are passed on to the cardiac myocytes, so the myocytes are called the cardiac contractile cells, and the sarcomere is the fundamental contractile unit of the cardiac myocyte. Okay, it is a compost of thick and thin integrating. Just like any other muscle fiber, there is always a myosin acting complex initiated by tropomyosin, chitin, and the troponin complex. Okay, so these are all the things. And cyclical increase in the intracellular calcium, which is responsible for the stimulation and the contraction. So this picture will show you how these things contract. So you can have the thick myosin filaments here, thin actin filaments are there. So in a relaxed state, you can see the muscle is longer in length because these actin fibers have not come closer to that. Whereas in a contracted state, it is the actin fibers which move closer to each other and shorten the length of the entire muscle fiber. So it is the actin which mainly gives the length, and by contracting is able to produce an effective muscle, force that is able to contract that. And how it is caused is by the application of this. So all these things you can use, and it utilizes the ATP for its contraction. And sometimes they may ask you about the zones and the bands that are seen. In, of course, FRCS is a very common question. H zone, there are I band, A band, which are nothing but the locations where the actin and myosin meet each other. So they you have the thin filament, thick filament. So when they come closer to each other, their color becomes different instead from the resting stage. And so that is how. So you can see this is the relaxed state of the myocyte or sarcomere, intermediate contracting state, then maximally contracted state. So the entire sarcomere from this length it becomes this shortened. So that is that produces the various bands or the distance between these fibers decreases. So that can also be sometimes asked. Now coming to the from the conduction system is mainly making the heart contract in unison. The atria should contract and empty the blood into the left ventricles or the right ventricles, and the ventricles should pump the blood out into the pulmonary or systemic circulation. So this is called the cardiac cycle. So this is another physiology question sometimes asked in the theory exam also. So how do you classify or what are all the various parts of cardiac cycle?
It can be divided into systole and diastole.
Systole and diastole. It's as simple as that. What we have studied in our basic physiology, they ask you again in your basic sciences first paper. So we have to recollect and keep memory of all these things. So cardiac cycle is defined as the succession of coordinated events taking place in the heart, and each heartbeat consists of two major periods, systole and diastole. Okay. During systole, heart contracts and pumps the blood through the arteries. During diastole, heart relaxes and it gets filled up. All these things are repeated in a cyclical manner. That is why it is called a cardiac cycle. Okay. So, what is the duration and components of the each cardiac cycle? How much is systole period? How much is the diastole period? So for that, we must know what is
5 seconds is 0.5 seconds is diastole.
So we must know how much the normal heart beat happens per minute, and for 60 seconds, if it is going to beat so many times, you must first of all find out what is the total duration of the individual cardiac cycle. From that, you must separate the cardiac systole time and diastole time. Okay. So when a heart beats at a normal rate of 72 beats per minute, each cardiac cycle will be 0.8 seconds. Okay. So 60 divided by 72 is 0.8 seconds. Of this, the atrial systole is only 0.11 second and the atrial diastole is 0.69 seconds. That is, if you make it together, it becomes 0.8. Okay. Whereas in the ventricle systole is larger. It's a longer time, 0.27, and ventricle diastole is 0.53, and together it is a 0.8 seconds. So both atria and ventricle, each one they contract only for 0.8 seconds, but the duration of systole in atria is slightly slower. Diastole is more to allow the blood to be filled up there, and whereas in the duration of systole in ventricle is slightly longer for pumping the blood, and diastole is slightly shorter. So but when we talk about systole and diastole, it is the ventricular systole and ventricular diastole we commonly talk about. We don't take into atrial thing into conduction. And out of this, there are isovolumetric contraction, rapid ejection, and slow ejection in the systole, which is divided into various categories. And the diastole is divided into isovolumetric relaxation, rapid filling, slow filling, and period of diastasis, I mean atrial systole or final filling. Now, what is the importance of atrial systole to the heart? How much percentage of blood it helps to pump it into the ventricle? Normally, the
70
filling
to
of
80%.
ventricle occurs by
25% of 25% of the
20.
cardiac
very, very small percentage only in health is supplied by or it is pushed into the ventricle from by the atrial contraction. But when the patient goes into heart failure, is there very the atrial systole, does it become more important? Yes, it becomes. Yes, it's known as the last rapid filling phase or pre-systole phase. It is usually considered the last phase of ventricular diastole, and the duration is 0.11 second. During this period, only a small amount, 10% of blood is forced into the atria. But if the patient goes into adjunctive failure, it is the atrial systole or what is called the atrial kick, which becomes more important to cause the left ventricular filling. Whereas in health, it plays a very limited role. Okay. Now, what are the various stages of cardiac cycle? Because this is another question that they may ask you. So all of you should know all these things. Atrial diastole starts after atrial systole. Simultaneously, ventricular systole also starts. And so the events can be divided. What are all the ventricular events? You can say isovolumetric contraction period, ejection period, total diastole, isovolumetric. This is a combination of both systole and diastole given in various phases. Of course, all this we can easily read in the books. And how the first heart sound is caused by the closure of atrioventricular valves. To go back to the very, very basics. And the ejection period is due to the opening of the semilunar valves and the isotonic contraction of the ventricle, plus is ejected both ventricles. This period is called the early ejection period, 0.22 seconds. And the ejection happens in two phases. The first stage is called rapid ejection phase of the left ventricle. Starts immediately after the opening of semilunar valves, and during this stage, large amount of blood is rapidly ejected from both the ventricles, from the left into the systemic circulation and from the right into the pulmonary circulation. Then the second stage is the slow ejection period. During this period, blood is ejected slowly, and that duration is 0.09. So earlier it was 0.22, now 0.09, and then the protodiastole phase is the stage before the full diastole. Then there is isometric relaxation, which means the length of the cardiac muscle does not change, only the tension decreases. And there is a rapid filling happening because of the pressure difference between the atria and ventricle. And the third heart sound sometimes will be heard even during normal physiology. If the rushing of blood from the ventricles to the from the atrium is rapid, then you may hear a third heart sound. Whereas the fourth heart sound is always a pathological sound, which happens because of the difficulty with which the blood is pushed into the heart. Circulation. So then there is a slow filling of the heart. Then again, these are the various stages how they can cause this, and this is the graphical graphical representation of the atrial and ventricular pressures that happen in the. So if you see the arterial waveform, this is how it goes. Then the dicrotic notch happens. So this is the pressure waveform for the right and left ventricles. So now we must know something about what is called the Wind-Kessel effect and what is the importance of that. How many of you have heard about this terminology, Wind-Kessel effect? Any idea?
The waveform,
Waveform?
arterial, the IBP monitoring waveform.
IBP monitoring waveform. It's called Wind-Kessel effect. Now I will ask you one question. See, we say there is a ventricular systole and diastole. Okay? During systole, the ventricle pumps the blood into the systemic circulation or pulmonary circulation, depending upon whether it is right ventricle, left ventricle or right ventricle. Okay? Then the semilunar valves close. The aortic valve closes, the pulmonary valve closes, and the ventricles, both right and left, go into relaxation, diastole. Now, how is the blood continuously flowing in our body during this closure and relaxation period of the ventricles, especially the systemic circulation? How is the blood? If you, strictly speaking, when the left ventricular systole happens, the blood should be pushed into the circulation. Then the valve closes, there is no blood flow at all. But does that mean that blood is not flowing into the periphery? Is there a gap in the flow?
No, sir, no gap.
No gap, no? So circulation goes on. Just like during respiration, at the end of expiration, end of inspiration to beginning of expiration, for that expiratory period, there is no oxygen uptake. But we continuously get oxygen. How? From where do we get the oxygen? In the gap between the end of expiration to inspiration, or through the period of expiration to inspiration?
From residual volume.
FRC, functional residual capacity. That is why it is called functional residual capacity. So whatever residual air is there in the lung, that only supplies the oxygen during your gap time between the inspiration and expiration. During expiration, air is only going out into the atmosphere. Whereas the FRC, which is there, 2.5 to 3 liters, which is there, that only supplies because the blood is pumping continuously, isn't it? Similarly, if the left ventricle causes a systole and pushes the blood into the circulation and then closes the valve and there is no blood flow for a brief period of diastole, how is the blood continuously circulating? Are you able to understand my question?
Yes, sir.
Okay. So that is done by what is called this Wind-Kessel effect. I will show you how it is done. The aorta is elastic, that it is actually responsible for the compressive effect that converts the basic systolic flow by the ventricular ejection into a smoother, more continuous outflow to peripheral vessels. Now I will show you a picture how it is done. So if you see here, when the left ventricle valve, aortic valve opens, blood is forced into the proximal aorta. Then what happens, because of the elasticity of the proximal aorta, it dilates like a balloon and allows the blood to flow forward. Then when the valve closes, this dilated aorta constricts and that pushes the blood, whatever is remaining, towards the capillaries. Okay, so that is a very, very important effect, or what is called the Wind-Kessel effect. When the arteries are normally compliant, a substantial fraction of the stroke volume is stored in the arteries during ventricular systole, and the arterial walls are stretched. Okay, so this is the aorta portion which is stretched out. You can see the dotted line. This is the original size. Now this becomes dilated like this. Then what happens, once the valve has closed and there is no further blood flow, blood cannot flow back. So what happens, this return of the stretched aorta, that pushes the blood towards that. So during ventricular diastole, the previously stretched aortic arteries recoil, and the volume of blood that is displaced by the recoil furnishes a continuous capillary flow through the diastole. Okay, so this is the main mechanism by which we are able to have a continuous flow of blood supply, and this point is not given in majority of even our standard textbooks, but this I found in a physiology textbook for anesthetists, which I found very, very useful. So I thought I will share it with you. So this is another way how the energy is changed. So during left ventricular systole, the elastic arteries are stretched outwards and blood flows here. And the systolic during diastole, what happens? The valves are closed, so blood cannot flow back, and the stretched arteries, they recoil to their original level, and that, so here during the pressure created by the ventricle, that pushes the blood. Once the ventricle relaxes and the valve closes, it is the recoil of the stretched arteries which is pushing the blood. That is why when people become aged and the vessels become atherosclerotic and stiff, they are not able to maintain their cardiac output during even normal times. They go in for a postural hypotension and all these things because the arteries are not able to produce a continuous blood supply. Is this point clear to you?
Yes, sir.
Yes, sir.
Okay. So if you have understood that, I will be very happy. So what factors are responsible for this Wind-Kessel effect is elasticity of the aorta, presence of peripheral resistance, that is SPR, and proper function of the aortic valve. So patients who have leaking aortic valves, they will not have this particular function because part of the blood will go back into the left ventricle. So three components are very important for this Wind-Kessel effect. One is the aorta should be very soft and supple and elastic. It should not become atherosclerotic. That is why aortic sclerosis, sometimes you would have seen that echocardiographic report, they say there is aortic sclerosis. The word sclerosis, what does it mean? Becoming hard. Okay, the word sclerosis means becoming hard. So if the aorta becomes harder, especially elderly people, when you read their echo report, they will say aortic sclerosis. That means the elasticity is gone, and the patient should have a proper SVR. So patients in shock, why they are not able to maintain their blood pressure sometimes? Because they have a peripheral vasodilatation. So when you give noradrenaline, that we improve the SVR and we improve the BP. Then the third thing is aortic valve should be properly functioning. So these are the three things. I hope you are able to understand this point well. Now coming to the next important gray area of CVS. what is mean arterial pressure and what factors determine mean arterial pressure?
Actually, it is a sum of diastolic
Diastolic
pressure and
and the pulse
1/3 of pulse
One
pressure.
third of the pulse pressure. Very good. That is how we calculate the mean arterial pressure. And what factors determine the mean arterial pressure?
systolic BP and then diastolic BP.
Chronotropes.
The definition of MEP is the average arterial pressure through one cardiac cycle, that is systole and diastole. Okay, the definition actually is it is the average arterial pressure through one cardiac cycle, that is both systole and diastole. MAP is influenced by both cardiac output and systemic vascular resistance. So your MAP depends on these two factors. Then how do you calculate MAP is by diastolic pressure by plus 1/3 of the pulse pressure or the difference between systolic and diastolic. Okay, and in the what is this waveform and what does it show?
It's a
This is
arterial.
intra-arterial
Invasive
waveform. Isn't it? When you do in IV intra-arterial pressure monitoring, you get a waveform like this. Okay, so this waveform, the starting point is here and goes up to that. So this portion shows the systolic. So when the wave starts from the baseline, goes to the 120. This is the pressure. So starts from 80, goes up to 120. This is the systolic period. And as it comes down, you find there is a, what is this bend called?
Dicrotic.
Dicrotic notch. Okay, so it starts from the, supposing this dicrotic notch is here, what does it mean? Instead of being here, if it is here, what does it mean? If it is shifted up, what does it mean? If it is shifted down, what does it mean? Supposing the dicrotic notch, instead of being here, it is here, or if it is shifted up here, what is the difference? What does it
Pulses
indicate? It indicates the peripheral resistance. Okay, this is normal resistance. If it is pushed up, that means blood is not able to flow. So the SVR is high. So dicrotic notch will be pushed up. If the dicrotic notch comes down, that means more blood is able to flow easily. So SVR is low. Okay. So this is a very important point that we must be able to find out. So based on this, sometimes we call this intra-arterial waveform itself as a 4-man Swan-Ganz catheter. Okay, so if you put an arterial line, if you are able to get a proper waveform, from that itself we can find out whether we have a normal systolic function, whether we have a normal diastolic function, whether we have a normal SVR or low SVR, high SVR, and mean arterial pressure. Everything can be found out from that. Okay. Now the next important thing is the pulse pressure. What is the importance of pulse pressure? Pulse pressure is the difference between systolic and diastolic. We have seen that when we want to calculate the mean arterial pressure. Now, what is the importance of this pulse pressure? When will you have a wide pulse pressure? When will you have a narrow pulse pressure?
In stenotic lesions will have narrow pulse pressure.
White.
Regurgitant lesions will have wide pulse pressures.
Aortic?
Aortic regurgitation will have wide
Yes,
pulse
you have water hammer or collapsing pulse. We have a wide pulse pressure. Okay, it is the difference between systolic and diastolic. A widened or larger pulse pressure occurs with several diseases, including aortic regurgitation, aortic sclerosis, severe iron deficiency anemia, where the blood viscosity is reduced, arteriosclerosis, and hyperthyroidism. Okay, where the systolic pressure will be high, diastolic will be normal, and that is the reason. And even pregnancy. In pregnancy, why the pulse pressure is high?
because of decreased diastolic pressure, decreased SVR.
SVR is low. So diastolic pressure comes down. Systolic is same. So the pulse pressure becomes wider, and that is why a pregnant woman's pulse is always bounding. Okay, so these are all the things which causes the widening of the pulse pressure. A narrow pulse pressure, on the contrary, can also be because of heart failure, uh, volume loss. When in a trauma patient, the SVR becomes very high to maintain the cardiac output, I mean blood pressure. So the diastolic pressure becomes high, systolic remains low, so the pulse pressure becomes very narrow. Okay, so blood loss, aortic stenosis, cardiac tamponade. In all these cases, systolic pressure decrease with diastolic pressure remain normal or high. So especially in hypovolemia, diastolic will be more. So that is how the narrow pulse pressure happens. It is a significant risk factor for development of heart disease. So if a patient has a persistently large pulse pressure or wide pulse pressure, that means that the heart is always under strain. And the pulse pressure is independently associated with increased risk of developing atrial fibrillation also. And narrowed pulse pressures are seen in dystonia, dysautonomia, or postural orthostatic tachycardia syndrome. So there is a syndrome called POTS, postural orthostatic tachycardia syndrome, where the pulse pressure will be narrow. And there is another entity called pulse pressure hypertension. That is, if the pulse pressure becomes too high, then it is also called pulse pressure hypertension, which is again an indicative of which can lead to heart failure later on. Okay, so these are all the things. So mean arterial pressure and pulse pressure are two things which I thought we'll have to know little in detail, because that's a gray area. Most of the times examiners, if they ask, the candidates find it difficult to answer. Then the next thing is they ask commonly about the JVP, the theory exam also. What are the characteristics of jugular venous pulse? First of all, how many positive deflections and how many negative deflections are there in the jugular venous pulse tracing?
3 positive and 2 negative.
3 positive and 2 negative. What are the 3 positive?
AC,
what is the name? A, C and V. Very good. And X descent and Y descent, or X negative, Y negative. Okay. So this is how the CVP tracing or JVP tracing will be there. So you have a atrial systole which produces the A wave, then atrial diastole, and there is a ventricular systole which causes the atrioventricular valve closure, and which produces the C wave and V wave. And between that you have a X wave and Y wave, which are also called X descent and Y descent. So all of you should know how to draw this CVP tracing, because CVP is a repeatedly asked question in the examination. So A wave is due to atrial systole, which causes increase in the intra-atrial pressure. And why it is reflected into the veins, into the jugular vein? When the right atrium contracts, how that waveform is reflected to the neck veins.
Sir, when the when the right ventricle contracts, the tricuspid bulges into the right atrium, which increases the pressure in the right atrium.
That is due to the C wave. See here,
Yes.
C wave occurs during isometric contraction of the ventricle due to bulging of the tricuspid valve. That is C wave. But A
Yes,
wave
sir.
is due to direct atrial pressure. Do you have any valves between the SVC and IVC draining into the atrium?
No, sir, it's valveless.
So that is the reason why the atrial pressures are directly reflected back into the venous system. Okay, that is how the jugular veins are able to transmit this atrial pressure. And C wave is due to the bulging of tricuspid wave, or it's also called contraction wave. When the right ventricle contracts, the tricuspid valve is pushed up. And the V wave is due to accumulation of blood during the late part of ventricular systole or protodiastolic phase of the ventricles. So these are the 3 positive waves, and the X wave is due to the downward displacement of the AB valve. The same tricuspid valve which gets pushed up during ventricular contraction is pushed down. So which causes some sort of a negative pressure, which causes a negative descent. And Y wave is due to the opening of the atrioventricular valve, the tricuspid valve opening due to maximum ventricular filling phase. That is the reason why you get the Y descent. And the AC interval, that is the positive wave A and C interval, measures the time of conduction of the cardiac impulse from the right atrium to the ventricles. And the AC interval corresponds to the PR interval in the ECG. And the AC interval is prolonged in cases of delayed conductivity in the AV bundle, which is an early sign of heart block. And in partial heart block, the number of AV is greater than the number of CRV waves. And in atrial fibrillation, A wave will be totally absent. So these are all the clinical applications of knowing about the CVP tracing. And this is a picture to show the correlation between the electrocardiogram, the pressure cardiogram, pressure tracings, and the left ventricular functional status. Now, another important thing we have to know is about the action potentials of atria and the ventricular myocytes. As I told earlier, SA node, AV node, and the bundle of His, all these things are mainly like electrical wires, which are just there to propagate the electrical impulse to stimulate the myocardium and make them contract. Okay, so the action potential of the electrical system or conduction system is different from the action potential of the actual myocyte, which contract to push the blood from one area to other. So we should know about the action potential. Can anyone tell me how do you number the stages of action potential of the pacemaker cells or the atrial and ventricular myocytes?
0, 1, 2, 3, sir.
0, 1, 2, 3. Is there a 4 or not?
Sir, in pacemaker cells, we have 4, which is continuous.
Pacemaker cells, we have how many numbers are there for pacemaker cells? 3 or 4?
3, sir.
3. What are the 3 numbers? What is the first number to start the depolarizing phase of an action potential?
Phase
What
0.
number we give? 0. Very good. Depolarization phase we give 0. Then repolarization phase.
We give 3.
Straight away goes to 3 in pacemaker cells, whereas in the myocytes there is a 1 and 2. Okay. So for remembering the action potentials of non-pacemaker cardiac myocytes, you remember this mnemonic: submit, plummet, continue, and plummet. Okay. This is mnemonic you remember to not only remember the depolarization and repolarization phases of the action potential, but also the electrolyte, which is important or which is responsible for the particular change that is happening in the action potential. Okay. So we have always, if you know the normal electrical physiology of any cell, there is a resting stage where there is a difference between the interior and exterior of the electrical charges of a cell membrane. So that is called the resting membrane potential. Normally, what is the charge inside the cell compared to outside?
It is
Negative or
usually
positive?
negative.
We have electronegativity inside most of the cells, isn't it? This
Yes.
negativity has to become positive for depolarization to occur. Okay. So submit in the word stands for sodium, which causes the phase 0 or the depolarization phase of the non-pacemaker cell contraction action potential. So when cardiac myocytes become stimulated, the resting membrane potential, which is normally minus 90 millivolts, becomes more positive, and an action potential is generated when that minus 90 becomes minus 70. Immediately all the membrane channels are open and the sodium travels from outside to inside to cause a positivity inside the cell. Yeah, that is called depolarization. So the 70 minus 70 is compared to minus 90, it is such little lesser, which is called the threshold potential. Then the action potential will be first summit, the voltage of changes to more positive, and this is called the depolarization or the phase 0 of action potential. Now the summit starts with the letter S, so you can remember it is caused by the sodium in the cardiac contractile cells or the myocytes. So sodium channels open. So if you see this picture from the resting stage, the depolarization starts because of the travel of sodium into the interior of the cell, converting the electronegativity into positivity. Up to plus 30 millivolts it will change. So this is the phase 0 of the atrial and ventricular myocyte contraction. Now the second word is the plummet, which is a potassium, which is causes what is called the phase 1. As the cells become more positive from the influx of sodium, these sodium channels begin to close, thereby reducing the influx of sodium. So because the positive charged sodium is coming inside, the negativity gets converted to positive. And so once the level is reached, say plus 30 millivolts, the sodium channels start closing and the positivity increase decreases. This action potential will then be plummet. It will start falling down as the voltage across the cell membrane becomes slightly negative. And this is because to compensate for the positively charged sodium coming inside, the cells start pushing out the potassium, which is also positively charged outside, to balance this increase of the sodium inside the cell. And that is called the phase 1. So the plummet starts with the letter P, and if you remember that action potential plummets because of the sodium involvement. So the sodium channels which have opened in phase 2, phase 0 have closed, thereby reducing the inward flow of sodium, and potassium channels open, pushing the potassium outside to balance for the increase in the positive charge inside the cells. So there is a slight repolarization of the cell that is taking place. And so phase 1 is called the plummet phase, caused by potassium ion. And if you see the picture, phase 0, which is total depolarization, is done by sodium. Then sodium channels close, potassium is pushed out to bring back some negativity into the cell, and that is caused by the pushing out of potassium. So this small drop from the maximum positivity that has been achieved is called phase 1. Now, if all the potassium goes out, it should straight come down to the baseline, but that does not happen in the atrial and ventricular musculature. What happened next? Third is the continue, which is responsible for phase 2, which is mainly caused by calcium. So after slight repolarization, that is slightly turning negative, the phase 1 then continues to remain positive because because of the fairly constant move of that is caused by the calcium which is going in, and that phase is called the phase 2 of the action potential. And if you see this picture, it will be much more easier. So phase 1, total depolarization caused by inward movement of sodium. So to compensate for that, there is a elimination or pushing out of potassium from the inside of the cell to the outside, causing mild repolarization. But then calcium starts entering the cell, which is also positively charged. So that continues to cause a plateau state of positivity. Yes, that is the continuation of depolarization is maintained. So depolarization, mild repolarization, maintenance of depolarization by calcium inward movement. Then again more potassium is pushed out in phase 3 to bring back the negativity of the inside of the cell. So plummet again continues. So here what happens? After the calcium channel is also closed, more potassium is pushed out and the negativity is restored, and that becomes the phase 3. So if you see all the phases of the cardiac myocytes, both the atrium and ventricle, there is a phase 0 which is depolarization. There is a phase 1 mild repolarization, phase 2 which is a continuation or maintenance of depolarization, and then phase 3 where again the voltage plummets. Plummets means falling down. So it falls down to become repolarized. So depolarization, plummet to cause slight repolarization, continue to produce depolarization or maintain depolarization, and plummet back to repolarization. So if you have to draw the action potential of a myocyte, which is a contractile element, you have to draw phase 0, phase 1, phase 2, and phase 3. And phase 0 caused by sodium, phase 1 caused by potassium, phase 2 caused by calcium, and phase 3 again caused by potassium. That is why you remember summit, plummet, continue, and plummet. These 4 mnemonics, if you remember, you can remember the phases of action potential and the ions which are responsible for that. Is it clear for you?
Yes, sir.
Okay,
Yes, sir.
right. Then there is a resting phase where the baseline has come, then it is called phase 4. So action potential is complete. So starting from phase 4 only, we will have phase 0, then 1, 2, 3, then it comes back to 4. So there are actually 5 numbers: 0, 1, 2, 3, 4. But the depolarization, we give the number 0. Then we continue with 1, continue with 2, continue with 3, come to phase 4, which is the resting membrane potential. Okay. Whereas the pacemaker cells, they are mainly by SA node and AV node and the Purkinje fibers. And for that, you have to remember only 2 words. One is climb, second is plummet. So climb is caused by calcium, which is again phase 0 because it is a depolarization phase, and plummet is caused by falling down, repolarization. So unlike the myocytes, which have got a mild repolarization, plateau phase of depolarization, and then going in for full repolarization, that 1 and 2 phases are not there in pacemaker cells. So if you remember that, it is much more easy. So phase 1 is instead of the sodium which is causing the phase 0 in cardiac myocytes, it is the calcium which causes the phase 0 or the depolarization phase. And the plummet, the next only this phase is there. So this picture will be very easy for you to remember. So phase 0 or the depolarization phase is caused by calcium here in the SA node and AV node, and there is no phase 1 and phase 2 like the myocyte. It straight away goes into plummet. Potassium is pushed out and repolarization and coming to the baseline, and you can see here it goes to the baseline, beyond the baseline, little more than that. So if you see that picture, resting phase, you can see here, this is a comparison between the atrioventricular myocyte and SA node. Here you have the phase 1, phase 2, which is not present. So you straight away go to 0, come back to 3, and phase 4, because again it automatically goes for the next thing. This baseline becomes flat. Once the stimulation comes, then only the next contraction will start. Whereas here, there is an automaticity. There is a voltage change automatically takes place. So the baseline you should, for SA node and AV node, you must always draw in a little upward fashion and not a flat line. So that is a small change that you have to remember so that you can completely understand how the automaticity and regularity of the SA node firing happens. So there is a resting membrane potential is not static like this here. It is always dynamic. So it automatically stimulates its own next contraction. So You can see this is another depiction of what type of calcium channels open for producing the phase 0 in pacemaker cells. So the T-type channels open to bring it to the from the resting membrane level to the threshold potential. So for that there is a separate type of channel called the T-type. Then once it comes to the threshold potential, the L-type channels open to cause the depolarization. Then the potassium channels open and the repolarization acts. And you can see that, as I told earlier, this is the baseline which overshoots and comes below because there is a slow sodium channel leak which causes the automaticity. So this sodium leak is responsible for immediately stimulating the next trigger for depolarization. So the automaticity is maintained by that. Whereas in the ventricular action potential, you have the baseline 4, active depolarization 0, then there is a slight repolarization phase 1, plateau caused by calcium phase 2, then there is a sudden drop with potassium, and again it comes back to phase 4 or resting phase. So these are all the ions that are responsible in the pacemaker cells. Calcium entering through to T-type channel, bringing it up to the threshold potential, then through the L-type channels, causing the depolarization, then potassium extrusion, causing the repolarization, and slight. This is also called the funny sodium current. There is always a constant leak of sodium in the action potential cells or the pacemaker cells. Whereas the depolarization in the ventricular myocytes is mainly by the sodium. Then there is a plateau maintenance by calcium and potassium for the initial repolarization and the final restoration. So these pictures will be able to help you to remember that. So this is a very frequently asked question in the theory paper. Describe and compare the action potentials of pacemaker cells with the ventricular myocyte. I hope you are able to understand it without any confusion. Now, what are the practical applications? Why we should know about this action potentials? Because the arrhythmias in the heart action take place because of this. There are 4 different classes of antiarrhythmics, including sodium channel blockers, beta blockers, potassium channel blockers, and calcium channel blockers, which are used for treatment of the various arrhythmias. So each class of medication functions by blocking different phases of the cardiac myocyte or pacemaker cells. So the mnemonic to remember for the classification of antiarrhythmic agents. This is another pharmacology question that is very frequently asked in the theory. Sodium blocks potassium channels. If you remember this mnemonic, you can answer. There are 4 classes: class 1, class 2, class 3, class 4. And class 1 is subdivided into 1A, B, and C. So totally there are 7 classes. So the first class of drugs, they act on the sodium channel. The second class of drugs, they are beta blockers. So that is mnemonic tells B blocks. Third class of drugs act on the potassium channels, and the fourth class of drugs act on the calcium channels, the L type and T type, what I showed you. So the pathology, how arrhythmias happen, problems with conduction system heart lead to heart blocks and dysrhythmias. The conduction disorders can affect SA node or AV node or the bundle of cysts and its branches. All these things can be affected. So there are also disorders in the ion channels which can lead to what is called the long QT syndrome or Brugada syndrome. So it may be a direct involvement of the pacemaker stimulation cells or the conduction system, or it may be a fault in the ion channels which permit the entry of sodium, calcium, potassium for causing the various electrical changes. And how it is regulated, the autonomic nervous system influences the cardiac action potentials. So increase in the sympathetic activity stimulates the beta adrenergic receptors in the heart to increase the heart rate and cardiac contractility. And the slope of phase 4 pacemaker cells and augmenting the phase 2 in non-pacemaker cells respectively. So when the beta stimulation happens, it causes the slope of the phase 4, that is the resting phase 4, to become more taller, to stimulate the heart much more frequently. And that is happening in the pacemaker cells. Whereas in the contractile phase, if you prolong the phase 2, where calcium is able to maintain the depolarization, the muscle will be contracting for a longer time. That will increase the ionotropic effect. So the chronotropicity is increased by acting on the phase 4 of the pacemaker cells, and the ionotropic effect is produced by action on the phase 2 of the contractile or non-pacemaker cells. Whereas the parasympathetic system activity acts on the muscarinic cholinergic receptors to normalize the heart rate by slowing the rate of depolarization. So by reducing the depolarization of the pacemaker cells, that is the entry of calcium, if you reduce, the depolarization will reduce. So that is how the parasympathetic system is able to bring down the heart rate. Whereas the sympathetic system is able to increase the heart rate by increasing the slope of the phase 4 of the pacemaker cells, not the contractile cells. But in the contractile cells, it prolongs the phase 2, but to increase the contractility or ionotropism. So this is the basic function that we have to understand. Now, another common question, we will finish with that. I think about one batch ago, previous exam, it was asked, describe the various cardiac vascular reflexes. Can you name a few of the cardiovascular reflexes?
Bainbridge reflex, sir.
Reflex, Bainbridge.
Bainbridge
Oculocardiac reflex.
Oculocardiac reflex 2. Then
Baroreceptor reflex, sir.
baroreceptor reflex 2, 3. Anybody else who want to add anything more? Is there, or only 3?
Chemoreceptor reflex. Push.
So important thing, you must first start from baroreceptor or carotid sinus reflex or pressure receptor reflex. What is the importance of this baroreceptor reflex? What is it help in?
Inhibit the cardiovascular tone at the normal blood pressures and maintain vascular tone at
Our
hypotension.
maintenance of normal blood pressure is done only by this baroreceptor reflex. Okay, so if all of us have to have a normal BP of 120/80, we have to have this baroreceptor reflex well intact. Otherwise, we will have a fluctuation. Okay, chemoreceptor reflex, Bainbridge reflex, which is also called the atrial reflex or atrial stress reflex, Rizal-Jaris reflex, oculocardiac reflex, Cushing's reflex, and Valsalva maneuver. So 1, 2, 3, 4, 5, 6, and 7. So we have to write all about the 7 reflexes in our answer paper if the question on cardiovascular reflexes is asked. So going to the baroreceptor or pressure reflex, for all the reflexes we must know the afferent, center, and efferent. Any reflex, that is how we have to write the answer. The reflex initiated by stretch receptors are called baroreceptors, which are present in the carotid sinus or aortic arch walls on the right atrium. They are present in the carotid sinus, aortic arch, walls of right atrium, entrance of SVC and IVC, and walls of left atria at the entrance of pulmonary vein. These are all the locations where these baroreceptors are present. These receptors in low pressure part of the circulation are also called cardiopulmonary receptors. They are stimulated by distension of the structure in which they are located. Pressure in these structures are associated with the discharge rate. Now you can see this picture tells you this is the carotid sinus, this is the aortic arch receptors. So baroreceptors are also situated mainly in these two areas, but also in other areas like what has been described here. And what is the way it acts? So the afferent is sent from the which nerves carry this afferent stimuli. And supposing this carotid sinus gets stretched too much, and it senses that, which nerve will be taking this to the brain? The hypothalamus.
Glossopharyngeal and vagus nerves takes medulla.
Cranial nerve, 9 and 10. Okay, so these are the two nerves which will be taking the information that the vessels are getting too much stress to the hypothalamus, and then go to the brain also, and then there will be inhibition by the parasympathetic vagus nerve coming to the SA node, and sympathetic drive also will be blocked, so that you will restore the blood pressure to normal activity. Okay, so respond extremely rapidly to changes in BP within seconds, fraction of seconds. The importance of this reflex is to keep the arterial pressure relatively constant, and short-term regulation of blood pressure in the range of 70 millimeters to 150 millimeter. Maintain the mean pressure at about 100 millimeters. That is mainly done by baroreceptors. And pressure buffer systems which reduce the blood fluctuation during daily events such as changing of posture, respiration, and excitement. All that is controlled by baroreceptor. And baroreceptor resetting is a word. What is the importance of this resetting? Which people the resetting will happen?
Hypertensive.
Chronic hypertension, excellent. Will be will a change in the blood pressure. This elevate, if the blood pressure is elevated for a long time, that is in chronic hypertension, the set point will transfer to the elevated mean blood pressure. So the mean pressure, instead of being 100, it will be always 140 or 150 in a chronic hypertensive who has not taken medication to control that. Okay, so in those patients, the mean pressure is important for perfusion of organs. It is not the systolic or diastolic which determines the blood flow. It is the MAP which determines. So here especially the cerebral blood flow auto-regulation is kept at a higher level in patients with chronic hypertension, and that is why we have to know about this baroreceptor resetting. So there is a decreased baroreceptor response in patients with chronic hypertension. This makes the baroreceptor system unimportant for long-term regulation of arterial pressure. So calcium channel blockers, AC inhibitors, phosphodiesterase inhibitors, they all decrease the cardiovascular response of increasing BP through this reflex. If the patient is on all these drugs, you have to be very careful that they cannot augment their BP when there is a fall. So baroreceptors are compromised in diabetic neuropathy, autonomic neuropathy also. And volatile anesthetics like halothane inhibit the heart rate component of the reflex. So it will be a heart rate depression. Even when there is a BP fall, instead of increasing the heart rate, they will keep the heart rate low. And these reflexes are well preserved with moderate doses of fentanyl, but high doses reflex this reflex. So these are the clinical application of the knowledge of baroreceptor about the antihypertensive drugs which are used, volatile anesthetic agents which are used, and pathological conditions like diabetic nephropathy. They all affect. That is why postural hypotension happens in autonomic neuropathy of diabetes, because the baroreceptor reflex is not properly functioning. And drugs like fentanyl, how they affect also we have to know. Now coming to the central and peripheral chemoreceptors, which are the second category, the chemical composition of blood and the surrounding fluid, the central chemoreceptors respond mostly to acidosis, because in acidosis there is a lack of oxygen supply to the tissue. So there is always a increased production of hydrogen ions because of anaerobic metabolism, and lactate also increases. So these receptors mainly respond to acidosis, and they are sensitive to changes in both arterial carbon dioxide and oxygen. So increasingly important when mean arterial pressure falls below 60 millimeters of mercury. And the third receptor is reflex is the Bainbridge atrial reflex or stretch reflex. It is a volume reflex. So stretching of the atria stimulates stretch receptors present in the right atrium and iotocaval junction and the or atriocaval, which is carried by the vaguely mediated afferent fibers, which leads to cardiovascular strength and stimulation of medulla. And efferent also comes through vagus nerve, which causes parasympathetic decrease in the parasympathetic activity and increase the heart rate. So when the volume increases, all these changes happen, and they directly stimulate the HA node also. So that is the right atrial stretching, because HA node is situated close to the SVC opening. That also stimulates the heart rate. So the Bainbridge reflex and the baroreceptors act antagonistically to control the heart rate. So the baroreceptor reflex acts to decrease the heart rate when blood pressure rises, whereas when blood volume is increased, the Bainbridge reflex is dominant, and when the blood volume is decreased, the baroreceptor reflex becomes dominant. So both these things are interrelated in maintaining the heart rate, which we have to understand. Now there is another reflex called Basal-Jarvis reflex, which is a reflex producing the triad of hypotension, bradycardia, and coronary artery dilatation. Okay, and the afferent for this is the unmyelinated vagal type C fiber, reflexively increase parasympathetic tone. That is why you get the bradycardia. As it involves bradycardia, this reflex is thought also as a cardioprotective reflex and implicated in physiological response in a range of cardiovascular conditions like myocardial ischemia, infarction, thrombolysis, revascularization, and syncope. And so orthotaxism, preload decrease in cardiac output blood pressure, and which immediately will stimulate baroreceptor stimulation. So that will stimulate catecholamin release, and this will also cause a decrease in end diastolic volume, LV inotropism. So on one line there is a depression caused by the decrease in the other side. There is a compensatory mechanism that's going on, and the vigorous contraction leading to activation of LA mechanoreceptors. At that time only this Basal-Jarvis reflex will come. When the LV mechanoreceptors are stimulated, you will get what is called the Basal-Jarvis reflex, which will cause increase in the vagal tone, which will cause cardio-inhibitory component, and that will another block the sympathetic tone, which will cause the vasopressor component, and there will be a reflex syncope happening in this. And the direct stimulation, especially when they do coronary interventions and they push the catheters, that also can cause this Basal-Jarvis reflex. So the cases that you hear in the sudden cardiac arrest in coronary cath lab, all that is because of this particular reflex only. Then the fourth reflex is the oculocardiac or trigeminovagal reflex, which all of you know is also called the Ashner reflex, and it is mainly by the pressure on the extraocular muscles, mostly due to the squint surgeries. Okay? So what conditions cause this oculocardiac reflex? These are the ophthalmologic procedures like strabismus surgery. Other stimuli which can trigger this reflex is the direct pressure on the globe, or ocular manipulation, ocular pain secondary to increased pressure, retrobulbar blocks, ocular hematomas, facial and orbital trauma, which induce or activate the reflex. And the pathway for this reflex consists of an afferent and efferent limb. Afferent is of course by the trigeminal. That is why the name itself trigeminovagal. Trigeminal is the afferent pathway, vagal is the efferent pathway, and vagus is the efferent line. So what will be the effect of this, and what is its special character? That's oculocardiac reflex.
Increases the parasympathetic tone and bradycardia.
Bradycardia. What is its special character?
On deepening the plane, Usually.
Deepening the plane should abolish anything, but repeated stimuli, it will fatigue the reflex. So
Yes.
that is why in strabismus surgery, when this reflex occurs and the heart rate goes down, you ask the surgeon to stop, and after a few minutes, you ask him to start again when the heart rate comes up. Again, if it goes down, you again wait for a few minutes, then again restart. By the third or fourth time, the heart rate will stabilize. It will never go back to bradycardia. So that is called the fatigue happening in the reflex. So that is the special characteristic. Due to the activation of vagal motor response and other reported vagal effects, hypotensive episodes, syncope, and gastrointestinal repercussions happen. This is a fatigable reflex. That is what you have to understand. This is a fatigable reflex. Intensely will decrease with multiple or repeated stimuli. So that is what will happen in strabismus surgery. Even if you stimulate again and again, after a few minutes, it will all settle. The heart rate will remain stable. It will not go back to bradycardia. What are the ways and prevention of treatment of oculocardiac reflex? This is, I think, this question was asked in the last examination. The trigeminal-vagal reflex was one of the questions in the last theory examination. Immediate cessation of triggering stimulus, retrobulbar or peribulbar block, if it has been given, or if it is not given, you can give and block the ciliary ganglion. Though its stimulation of sympathetic activity, ketamine also has been used to block this reflex. And pre-treatment with anticholinergic like atropine or glycopyrrolate will also help in preventing this. So this is the pathway, especially for strabismus surgery. The stimulation happens, goes to long and short ciliary nerves, afferent pathway, goes to the trigeminal ophthalmic branch, and goes to the main sensory of the trigeminal gland. Then from there, motor nucleus of vagus is connected, and the efferent pathway is through the vagus, causing cardiac depression, bradycardia, all these things. Then the Cushing's reflex. What is the Cushing's reflex? What are all the components of Cushing's reflex?
Increase in
Hypertension, bradycardia, and irregular respiration.
Response, respiration. Very good. Who described that? Is it an anesthetist or a physician or a surgeon?
Probably
It is by
physician.
Harvey Cushing, a neurosurgeon. Okay, he was the one who is responsible for describing this. The Cushing's reflex, which is also called vasopressor reflex, Cushing's reaction, Cushing's effect, Cushing's phenomena, so many words, is a physiological nervous system response to acute elevations of intracranial pressure, resulting in a triad of widened pulse pressure, bradycardia, and irregular respiration. Okay. So these are the three things. Hypertension. That is why the widened pulse pressure is happening. And Cushing's reflex was first proposed by Dr. Harvey Cushing. He was a neurosurgeon. Another contribution, can anyone say by Cushing related to anesthesia?
Cushing's ulcer, sir.
Cushing's
Ulcer.
ulcers. It is related to our specialty.
From the
He
burns.
was the one who introduced the system of intraoperative monitoring and documentation of that. He allotted a separate nurse because those days the multiparameter monitors were not there. So when he was doing neurosurgery, he allotted a nurse to check the patient's pulse rate and BP every 5 minutes and make a note of that. So he is considered as the father of intraoperative monitoring documentation, just like your anesthetic chart that was introduced by him only, because he wanted to know the status of the patient after he completed the surgery, at what stage the BP went up, at what stage BP went down, to analyze which areas of the brain he is stimulating. So he was so nice to thought of it as a simple measure of finding out which area of the brain he is stimulating when he is operating. So the credit goes to him for introducing the documentation of intraoperative monitoring. So he believed that dramatic increases in blood pressure is a reflex brainstem ischemia seen in patients with raised ICP and the mass effect. The proposed system of vasoconstriction and subsequent rise in systemic blood pressure was due to all these events. So, Cushing's triad is a late sign of increasing ICP and indicates that brainstem herniation is imminent. So, this is how the whole thing happens. And this triad is increase in systolic BP, decrease in heart rate, and irregular respiration. And Valsalva maneuver, another question that is commonly asked. It's a post expiration against closed glottis. That is the description how it works. It mimics many routine activities like straining during defecation. Patients who are constipated, if they start straining during defecation or blow up balloon or play wind instruments, all these things will result in a maneuver like Valsalva. What are the various phases of Valsalva maneuver? This is a common question that sometimes examiners may also ask you in practical examination. What is the indication for asking the patient to do Valsalva maneuver? Especially in diabetic patients.
For the autonomic neuropathy.
To assess the degree of autonomic neuropathy or autonomic imbalance. Okay, so it is one of the recommended tests for the identification of diabetic autonomic neuropathy in patients with diabetes, long-standing diabetes. So there are 4 phases of this. Phase 1, which corresponds to the onset of the strain, which is associated with a transient rise in blood pressure because of the complete pushing of all the blood in the thoracic vessels into the heart. So venous return increases, so there is an increase in cardiac output. Then phase 2 follows when the intrathoracic pressure is still high, which prevents the venous return. So in the first phase, all the vessels are squeezed. Intrathoracic vessels are squeezed to, that is the venous vessels, to improve the venous return. But after continuation of the intrathoracic pressure increase, venous return is prevented. SVC and IVC cannot drain into the heart. So preload falls, so stroke volume falls. So in order to compensate for that, the baroreceptors should come into play, and thoracic sinus and aortic arch will have to increase the sympathetic activity, leading to marked tachycardia, increase in cardiac output, and increase in peripheral vascular resistance, which is the normal response that should be seen in healthy individuals. In the phase 3, transient phase involving release of strain. So first phase 1 and phase 2 only you hold the breath and increase the intrathoracic pressure. In phase 3, the patient will be releasing the intrathoracic pressure. So there is a sudden dip in blood pressure. And because of the expansion of the pulmonary vascular bed and reduce left ventricular crossover of the blood. And phase 4 will be overshoot of blood pressure above the baseline, which because of the resumption of normal venous return and the sympathetic nervous system, which happened during the phase 2. The overshoot of blood pressure leads to stimulation of again baroreceptor reflex, leading to bradycardia and return of blood pressure to normal in the baseline. Whereas this should not happen in the patients who have autonomic neuropathy. So what are the indications to perform? Used as a measurement of autonomic function or a marker for heart failure or termination of arrhythmias or murmur differentiation. These are the 4 indications for which we can do Valsalva maneuver. So detecting bleeding points towards the end of thyroid surgery, also some surgeons will ask you to increase the intrathoracic pressure by occluding all the, closing all the valves and then giving a good squeeze on manually ventilate the patient and give a compression that will increase the pressure and produce an effect like Valsalva to see the bleeding points, or diagnosis of varicocele in the spermatic cord, that also you can use for that. And to assist in some radiological diagnosis like liver hemangiomas or venous diseases, or for the presence of foramen ovale, to confirm hemostasis and the absence of cerebrospinal fluid leak after neurosurgical procedures, to reduce any puncture pain in pregnant women. You can ask them to do a Valsalva maneuver that will reduce the any puncture pain. contraindications in whom you should not do: coronary artery disease patients, patients with valvular diseases or congenital heart disease patients. You should better avoid all these tests. And patients who have already intraocular pressure rise or intra-abdominal pressure rise, you should not do that. And so this is what the change that you will see in the 4 phases. So in the first phase, there is an increase in the blood pressure and decrease in heart rate. Then there is a decrease, then corresponding heart rate increase, overshoot. All these things are described in this picture. So there are further more topics to be covered. I think we will stop here. We have already taken course a lot.